Welcome to this webinar organized by the Fujita Alumni Association. This is a wonderful day because we have very interesting topics today, but before introducing the speakers and their topics and their titles, let me welcome Professor Yoko Kato first. Thank you, Professor.
日本語 or English? 日本語
Oh,
はい、皆さん。
日本語 if you want.
I cannot speak Italian, sorry. So, こんばんは。Good evening. Maybe good morning, good afternoon, please. So, thank you very much for joining our alumni webinar. So, but our alumni is extended, the more and more. So, because of the 2 months rotation. So all the time, maybe 4 or 5 colleagues studying together at Fujita Bantane. So hopefully, I think they can learn a lot among us. ありがとうございました。どうぞ。
Thank you, Professor. For sure, they are learning a lot from you and also hopefully from these webinars that we are running since December 2020. So it's a long time. And I think the topics are always very intriguing. The discussion is also very active, and I have to thank for this my co-moderator, 𝑫𝒓 𝑫𝒖𝒓 who is always here supporting, as well as Raja and Liu for the organizational and logistic point of view. Thank you also to our commentator, Ashish Kumar, and to our discussants, Dr. Biswas, Dr. Sukirti, Dr. Felici. Thank you, all of you, for your help and your support. But we should start. The webinar today includes 2 speakers who are going to talk about very interesting topics, Professor Gleb Danilov and Dr. Temur Dushanov. The topics are intriguing because they are really something new, something cutting the edge, artificial intelligence from one side and endoscopy in spinal surgery from the other side. So we can start with the first speaker. Let me introduce Dr. Gleb Danilov. He is a neurosurgeon, but he is also a clinical researcher, a biostatistician and statistical programmer, data scientist and software developer. He is working at the Burdenko Neurosurgery Center in Moscow, Russia. And he is the head of the Laboratory of Biomedical Informatics and Artificial Intelligence at that institution. He published a number of papers in peer-reviewed journals. I think the topic today will raise a lot of discussion because the title is Introduction to Artificial Intelligence in Neurosurgical Research. So it's a pleasure for me to welcome Professor Danilov to start his talk.
Thank you so much, Professor Felici, for your kind introduction, and thank you, Professor Katar, and all the colleagues for having me today. That's is an honor and privilege and great opportunity to have a talk on a really exciting topic. So my talk is focused on artificial intelligence and neurosurgical research. Let me share my screen. So I hope you can see the presentation. Is it true? Yeah, thank you so much. I will talk about artificial intelligence in neurosurgical research, but the general principles I will discuss in this talk are applicable in other areas of medicine. So the term artificial intelligence has become really popular today thanks to mass media and our intuitive common perception and our understanding of artificial intelligence, just literal understanding, is a robot with an artificial brain that thinks like a human, acts like a human, and that a robot is fast thinking and more knowledgeable than a human. And here comes the dangers. Soon it will replace us all. And that perspective provokes anxiety, but also serious skepticism. Why skepticism? Allow me to remind you, there are 80 to 90 billion neurons in the brain, each forming up to 10,000 synapses. So no existing computational power can simulate such a complex system. Our entire brain is not yet modelable. There is no artificial brain that can compete with human brain. And we can put a period here now, and I want to erase that anxiety from your mind. However, the efforts to educate computers to mimic human intelligence and human behavior have been underway since the mid-20th century. For instance, English mathematician Alan Turing, a pioneer in computer science, showed that a machine could convincingly present itself as human. The term artificial intelligence often comes with phrases like machine learning, deep learning, and neural networks, and I suspect that for most doctors, all this terminology is quite distant and unclear. Let's try to get a basic understanding of what it's all about. We'll start with the concept of artificial intelligence. Different people might mean different things by this term, which can lead to confusion. I propose we consider two approaches to defining this term. The first method is defining artificial intelligence in quite a narrow technical sense. So in a technical sense, artificial intelligence is a mathematical solution which automates intellectual tasks normally performed by humans. For instance, artificial intelligence can recognize complex visual objects, comprehend spoken and written language. It can produce intricate text, create images, and even exhibit creative capabilities. And these systems can engage in comfortable conversation with humans, assist in finding information, offer recommendations, translate languages, and even write computer programs. And today, all these services are available right at your fingertips through the mobile devices. But broadly speaking, the term artificial intelligence is used to name a branch of computer science that focuses on creating intelligent machines that can mimic certain human cognitive functions. I want to highlight the term mimic. They are mimicking, they are imitating. In that way, in that sense, this implies many technologies and many technologies that you can see on the slide. And a hallmark of contemporary AI technologies is their capability to learn from data, from lots of data. This process is known as machine learning. Machine learning is a computer technology. It's a computer technology on mathematical modeling. So obtaining a mathematical model based on sufficient amount of data. This technology is designed to tackle specific problems in many various fields. Machine learning is the process of summarizing your accumulated experience into a mathematical model. This model enables answering questions by relying on the necessary information. The model determines what information is valuable during the learning or training process. Let's formally examine this learning process. Suppose you want to predict a patient outcome based on the treatment you choose. You have already collected some data on the treatment outcomes for patients with various clinical characteristics, let's call them patient's features. You feed this data into a black box together with treatment outcome, and the black box selects the best mathematical model for prediction based on your data. So the result is a predictive tool. Thus, machine learning summarizes your accumulated experience into a mathematical model that you can then apply in practice. What can this model do? It can calculate the probability of different outcomes based on a given personal set of characteristics. I've presented machine learning as an unclear black box. Do we need to understand how this mechanism works, how it works? Do we need to know what is inside of that black box? Well, it is certainly desirable to understand, but you need to have specific knowledge and mathematical background, programming background to understand the details. But there are limitations. In reality, there are many types of machine learning, many types of these black boxes, and many models are different to interpret. They are difficult to interpret. Machine learning is a field where theory follows practice, and a successful experiment is the benchmark for success. If it works, it's good. If the model is good for you, that's perfect. To get more intuitive understanding of machine learning, let's do an imaginary experiment. Imagine this is a glass, and we have some sophisticated geometric surface at the bottom of the glass. We want to find a way to recognize this complex surface, to distinguish it from all other possible surfaces. Quite a complicated task. Let us pour some water inside the glass and let it freeze. Now, we have a piece of ice which is trained to recognize the surface. It learned it. In this case, we are not interested in the physics of learning, saying Brownian motion. We only need the result of learning. Now think of the surface as data and water as a model being trained. So if we pour the model on data, you literally get machine learning. But I want to ask some provocative questions. Just think about that. Do you really think that, do you really can call this intelligence, this process, can you name this process intelligent? Do you really think it's a human-like behavior? I don't think so. So today, machine learning is a cornerstone technology of artificial intelligence, but not the only one. And you have probably heard a term deep learning. Deep learning, you can find it on the diagram inside the machine learning area as a subtype of machine learning. This term is used to contrast with shallow learning. The gradation relies on architecture of models. So deep learning models are typically called artificial neural networks, in which a learning process is organized in layers. Deep learning is learning with neural networks, literally. And the shallow learning term is not strictly defined in AI. However, all models opposed to deep learning approach are referred to shallow models. And you see the list on the slide. Now, I believe most people today have heard of ChatGPT and generative language models, as they've been receiving considerable amount of hype, a considerable amount of attention recently. These AI technologies can engage in meaningful conversations with humans, compose poetry, write scripts, offer recommendations, debug computer code, and translate text. But I want to demystify and ground these technologies, and let me briefly explain how they work. So the methods used by large language models, such as ChatGPT, rely on a linguistic hypothesis that can be summarized as follows. The meaning of a word is determined by the words surrounding it, or in other words, its context. So modern language models succeeded at learning the statistics of language. They learn the statistics of how different words are used together in a language. These models can predict words and entire phrases based on the context provided to them, or prompts. To illustrate how it works, try filling in the missing word in this sentence. So gloomy autumn weather with heavy something pouring down all day. I think most of you will say the missing word is rain. However, one could also say water pouring or shower pouring. Formally, these are logical and correct. However, our language experience suggests that in this context, the word rain is the most commonly used. Similarly, language models learn which words are most appropriate in given context, enabling them to generate text that mimics traditional human abilities. But I just want to pay your attention to the process of mimicking. That is not a human intelligent behavior. That's imitating the generation of text because of some statistical knowledge about the language. Well, how can we relate all this technology to neurosurgery? But let's miss all the technical details because they're not very interesting for neurosurgeons in general. Well, today neurosurgery is a complex discipline, which development is dependent on the close integration of clinical and fundamental neurosciences and technologies. There are many of that. So neuroimaging, optical technologies, interoperative neuromonitoring and neuronavigation, metabolic navigation, awake surgery, intraoperative neuromonitoring, digital, additive technologies, stereotactic radiosurgery and radiotherapy, so you name it. Well, neurosurgery is really high-tech medicine. Why is the AI issue is important for neurosurgery? Why do we talk about that? Neurosurgery stands out as the only clinical discipline that provides the direct access to the living human brain for clinical research. And in neurosurgery, we routinely collect vast amounts of data that can potentially hide important information, how the human brain works and breaks. But how do we extract this valuable knowledge from data? And how can we use this data most effectively to address clinical challenges? I believe that artificial intelligence can come to help. These technologies are poised to tackle global medical issues, specifically through the automation of medical processes, namely data-driven diagnostics, clinical decision support, and prediction in mostly complications and treatment outcomes. The primary sources of data applicable for artificial intelligence in neurosurgery are neuroimaging data, genome sequencing, biosensors, wearable or implantable, and medical records, both structured and unstructured. And now I will provide some examples of AI technology research within specific areas of neurosurgery. And if you allow me to do that, I will base my examples on our own research findings at Burdenko Neurosurgery Center. And the first area is obviously very important. It's non-invasive safe diagnostics with neuroimaging. Let me show the example from neuro-oncology. The diagnostic procedures in patients suspicious of brain tumor typically start with neuroimaging, and there are plenty of brain modalities important for neurosurgeon to provide the best treatment possible. The key to choose the right treatment option or their combination in neuro-oncology is histological and molecular tissue verification with invasive biopsy, either during microsurgery or with minimally invasive stereotactic biopsy. And the histological and molecular diagnosis determines the decision on choosing either radio, chemotherapy, or microsurgical treatment. And neurosurgeons understand that this process very well. But now, just imagine for a second that we have a tool that can predict the tissue type without invasive and risky procedure. And in that imaginary situation, no bloody biopsy is needed and no risks related to biopsy are provided. Is that possible? In 2022, we conducted a study evaluating the quality of deep learning in subtyping gliomas into 4 grades based on preoperative magnetic resonance imaging. We used 700 MRI series in that experiment, and we obtained quite good results on the 4-level classification with 3D MRI objects, image arrays, especially differentiation between 1st and 4th grades, with less accurate model for the 2nd and the 3rd grades, reflecting the difficulties for a doctor, difficulties a doctor has when suggesting diagnosis by MRI. And the overall quality of our deep neural network model appeared to be good. So nowadays, a series of studies at Burdenko Neurosurgery Center is aimed at finding quantitative features of medical images that can indicate the tumor biological properties. Today, the subfield of medical data analysis, which links image features with biological biomarkers, including genetic data, is referred to as radiomics or radiogenomics. And here is the example of a study in which we attempted to identify radiomic feature, or you can call them image biomarkers, of schwannomas in type 2 neurofibromatosis with different genetic types. So what the process looks like. First, we pinpoint the region of interest inside the tumor. Then we delineated it by slices and created a volume of interest. Next, we calculated statistical objects or statistical characteristics that characterize the distribution of gray levels in the volume of interest. And please don't be scared with that diagram. So I will explain it. Special mathematics applied to images produce thousands of radiomic features, which we analyze and correlate with clinical biological targets. These diagrams display hundreds of radiomic features in a circular fashion. Each radial line represents a distinct feature, and each point on the line corresponds to the patient's value for the feature. Different genotypes are coded by different colors, so the colored patterns you see suggest that neuroimaging signatures might be somehow associated with genotypes. If there are no patterns on these diagrams, we could see the homogenic mixture of points, but we see these patterns. So somehow the genotype and image phenotype are associated. That's important. We had a fascinating experience using radiomics to predict the tumor to normal brain ratio of radiopharmaceutical uptake from glioblastoma PET scans. Our model's predictions showed a high correlation with physicians' measurements of tumor to normal brain ratio. And we conducted a meta-analysis of scientific literature in which radiomics and machine learning were used for the diagnosis of glial tumors based on MRI data. We saw decent results from these studies, very good results. I hope you see the metrics of quality. But also, we found significant heterogeneity and a lack of standards that could make such research more reproducible. So in a special study, we could successfully differentiate between 4 types of glial tumors with methodology we proposed, a methodology of standardizing the regions of interest. So we did not try to delineate the whole tumor. We used standardized regions of interest with a standard size, and we showed relatively high accuracy of machine learning models based on radiomic features extracted from the standardized regions of interest. And you can see this result on the slide. Very interesting results also have been obtained using radiomics in traumatic brain injury. The analysis of diffusion kurtosis magnetic resonance imaging allows for very precise identification of damage to the brain's axons. That's interesting. And the use of the extended range of quantitative characteristics we obtain through radiomics significantly improves the prognosis for traumatic brain injury. And the prognosis model in traumatic brain injury, especially in acute traumatic brain injury, is quite significant, as the patient's fate is largely determined by the level, localization, and nature of brain tissue damage. On the slide, there is an example of another work on automatic image classification, and namely classification of intracranial hemorrhage by CT. This is probably the most cited paper from our group. We trained a model on Kaggle data. You have probably heard about Kaggle, which is a repository and a platform for data science to compete with each other in various tasks. So we try to participate in such a contest. The task was to classify acute intracranial hemorrhage by CTs. We took the data, we trained the model, and then we applied this model to our own data obtained from Burdenko Neurosurgery Center, and we got quite good results. So the accuracy of each subtype identification was more than 0.8 or more than 80%, which is quite good. Very attractive branch of AI application in neurosurgery is microsurgical training. So in 2022, we embarked an interesting project supported by Russian Science Foundation grant. It is the analysis of surgeon movements and movement efficiency. Actually, some movement patterns. And we analyze both microscopic, so the position and posture of a surgeon, and also the microscopic images focusing on fine movements under high magnification. And microsurgical technique is a crucial factor in the efficiency and safety of neurosurgical care. So models can help objectify and refine the technique during the training process. So it can be very interesting and hopefully efficient training technology that we are working on now. So at the dawn of neurosurgical science, diagnostics required absolutely horrific, risky procedures. The procedures were risky for patients. But then came the tomographs, magnetic resonance imaging, computer tomography, and medicine became safer. Today, there's a new stage of development. There's an abundance of diagnostic information. We must learn how to extract the maximum benefits of it. And if today the artificial intelligence is something, fantastic, not really connected to real life, never knows what will be tomorrow. Now let's talk about quite familiar topic, risk management. So it's this topic is really old, and it came much earlier than artificial intelligence appeared in the scene. But AI technologies can advance this area of risk management and complications prevention. Let me be more illustrative. Evidence-based management of unruptured intracranial aneurysms might be grounded on the individual prognosis of aneurysm growth and rupture. On the other hand, predicting of treatment outcomes might be valued for balanced decision-making. We conducted a single-center study to predict the unfavorable outcome of unruptured aneurysm clipping with a set of machine learning algorithms over a structured feature space. And we managed to get some promising results which support those of other researchers. So hopefully that might become another useful tool in decision support and neurosurgery. Nowadays, we're working on the same models for endovascular aneurysm treatment. And another example is a prediction of post-operative speech disorders, speech dysfunction in neurosurgery based on cortical evoked potential and machine learning. That is also a really interesting topic. We try to predict speech disorder by measuring the potential and apply machine learning to become more precise in prognosis. One of the also promising and underdeveloped areas of artificial intelligence in neurosurgery is the analysis of medical texts. On the slide is one of our first work in that direction. It was aimed at predicting the duration of hospitalization based on narrative operative reports. And we were surprised to see that almost 80% of cases, in almost 80% of cases, the mean absolute error of prediction by artificial intelligence did not exceed 3 days. The prediction was absolutely correct in every 5th patient, and that sounds like fantastic. We try to reproduce these results with more sophisticated models such as GPT-3 language models, and we also get good results. However, neurosurgeons always tend to predict the length of stay better. So another important branch of AI application neurosurgery is evidence-based risk assessment for adverse events. And of course, since the models can process much more information than human can do, this is a way of personalization of neurosurgical care. An extremely important aspect that is not always given due attention in AI research is the extraction of information from medical sources. The problem is that the experts are not so good in extracting information, and you may be wondering, wow, why the doctor is not that accurate in information extraction. The problem is they are not they do not agree with each other. So if you ask 3 independent experts to extract information about, say, pulmonary embolism from medical texts, you will see a surprising result. We did that experiment. Only in 70% of cases, doctors agreed with each other, and in 30% of cases, at least one person disagreed with his colleague or his or her colleagues. So we proposed a special algorithm that can help with that problem. This is an information extraction algorithm that can work really well, even with a large amount of textual data. And the idea is quite simple. You do not need to read the whole case history to extract some facts. You just need to find specific context in which that fact appears, and then you proceed with that context. Our algorithm showed itself very well in information extraction task. Here you see the comparison of our algorithm to machine learning and in the task of pulmonary embolism identification in electronic health records. But what is more important, that type of solutions can be effectively used for data preparation for subsequent machine learning. So machine learning models that are trained on high quality data prepared with our algorithm tend to perform better, much better than without special preparation. And in our recent experiment, we observed that deep learning models' ability to discern the meaning of text largely depends on the quality of both text and the classifier. So the slide illustrates how proper labeling, text labeling, can achieve an accuracy of 0.99 in classifying neurosurgical text. So the conclusion of that work was that you have to pay real attention to what you write in case history. And finally, a significant focus for us today is researching medical texts to extract factors related to the efficacy and safety of neurosurgical procedures. With artificial intelligence, it's possible to model the meaning of words based on their usage context. So the meaning of each word can be represented as a vector, a set of numbers, allowing for mathematical operations on these meanings. So you can see a cloud of unique words derived from 90,500 medical records over 19 years of our work at a neurosurgical center. And in this universe, a galaxy of complication exists. In other words, there are some terms used in the same context as the term complication. This lexicon can be used to study the range of potential complications in neurosurgery and the nuances of using the word complications for its scientifically grounded definition. But which vector representation is best to tackle this task? We provided some experiments, and using the best vector representation, we constructed this galaxy of complication. And indeed, with this galaxy created with some AI technology, we can find cluster of concepts corresponding to infections complications, thromboembolic complication, etc. So this indicates that vector representation we chosen is suitable for studying other groups of words as well. So currently we are using this technology to explore the potential range of complication in neurosurgery and for definition of complication. And the very last example is a generative language model in neurosurgery. It's based on the GPT-3 model, which is fine-tuned on the text corpus of the National Medical Research Center for Neurosurgery, named after Nikolai Burdenko. This model is capable of generating text based on the prompt. So at the top is the phrase we suggest, continuing, and just below different phrases written by the model, and it does it really well. At our institution, okay, so a very good outcome of artificial intelligence technologies is possible reduction of the interval between diagnostics and treatment, and of course, cost savings. So I showed a few examples in AI research, but there are many more ideas and examples of using artificial intelligence technologies. So what about a professional attitude to AI in neurosurgery? What should we expect from AI today? First thing, I want to warn you against the humanization of artificial intelligence. Artificial intelligence doesn't equal to human. Basically, AI is believed to what AI is believed to do is to facilitate, speed up, and improve accuracy in neurosurgical routine and research. But being just a technology, it cannot replace a medical expert in responsible decision making, at least not today. Think about MRI as a very powerful tool, but it cannot replace a radiologist. So today we're still in progress of researching AI in neurosurgery, and I hope that in the nearest future we'll get some really helpful and really efficient results. At our center, there is a laboratory of biomedical informatics and artificial intelligence, which is very active. We have quite a lot of data since our center performed 10,000 surgeries annually, and we also have supercomputer facilities. So we are enthusiasts of artificial intelligence research at our center. So to conclude, the artificial intelligence really becoming a trend in clinical neuroscience, and we believe that artificial intelligence can really overcome the limitations of classical statistics in neurosurgical research. The main sources for machine learning, AI, deep learning are images and structured clinical data in neurosurgery. Text mining is still underexploited. And the introduction of artificial intelligence can really improve the quality and outcome of scientific research. We really believe in that. So thank you so much for listening to me. Thank you.
Thank you, Professor Danilov, for this very interesting talk about exciting topic. So let me start the discussion. I would like to kindly invite Professor Kumar Ashish. Are you here to give your comments?
Yes, I was actually sorting out my video and audio settings initially. So great lecture, Professor Danilov. Thank you so much. I think as we use ChatGPT in our research, we obviously see its advantages, and then you have given examples in clinical settings how it can use. What do you think is the major drawback? I know you mentioned that it cannot replace medical expert, but in terms of data quality, reproducibility, can we reproduce the same result over and over again? What are your concerns that in terms of assurance? Because we know ChatGPT can sometimes create references on its own which do not exist in actual literature. So, and it's basically processing that information from whatever is available outside. So in terms of the clinical application, in terms of, for example, radiomics, how do you think there are possible drawbacks in clinical context in the examples which you gave?
Thank you so much for a very important question. I do believe that the application of artificial intelligence should be mostly based on automation tasks. For instance, today we always talk about the substitution, the replacement of an expert by artificial intelligence. But as I've already told you in this talk, I do not believe this is really a problem, and I don't believe that it's possible. Why? Because if you see how ChatGPT works, if you see how generative model works, you will understand that these technologies do not think. They just imitating human behavior. They're imitating cognitive abilities, but they do not think. So they cannot be responsible. That means that you cannot trust a decision to a model that cannot be responsible for what it does. But since these models are really efficient in generating text and in general in automating something, you should tackle them. You should consider them in some tasks where automation is possible, but can be supervised by an expert. For instance, a good example is delineating multiple metastases in human brain when planning radio therapy. This is a task of automation. For instance, a mathematical model can delineate some, multiple metastases, and then an expert will take a little time just to correct the contours, the segmentation. That is not such an intelligent task. It's not a decision making. It's not about taking responsibilities, but it's quite a complicated task that requires human attention. And so this is example how you can apply artificial intelligence. Do not think of this technology as expert level technologies. Find some automation tasks that are simple, and you will succeed with the modern AI, I would say.
Thank you. One more question, if I can ask. I saw that your work has been tremendous in this area for many years, like over 10,000 operations every year. So at your center, are you now comfortable saying that probably we don't need actual biopsy for a patient with GBM by using the deep learning models, or you still think that this is still under evolution and probably you need more work in years to come?
Yeah, thank you. Thank you. The problem is that no digital biopsy exists by the moment. It's really hard to create digital biopsy because you need tons of data and the classification of tumors, of CNS tumors, is always evolving. So even if you can create some type of digital classification tool, it will be broken just in 1 or 2 years. That's a problem. And of course, you need to have lots of images. I do not know if there are any facility in the world that can provide such amount of data for digital biopsy modeling, machine learning. So these are still fundamental research.
Thank you so much. Thank you so much.
Thank you, Ashish. And Professor Danilov, thank you for your talk. You actually got to the point that this kind of technology is not intelligent in the sense that we cannot rely and trust this technology at all. But it's a great technology when it comes to analyzing big data. This technology is proved to perform better than human beings sometimes. Also in our center, we did some kind of research about that, especially about the ability of this technology to recognize, for example, which muscle is producing an electro recording during our operation, thanks to the work of our assistant professor, Dr. Boaro. So we could see that the machine is able to detect the muscle better than the human being based from the micro retro recording. But still we can get to an accuracy of more than 80%, as you said also during your lecture. So my question is, how do you think we can further improve this accuracy? What's the limitation nowadays? Is that a matter of amount of data? So we need to give the machine more data to increase this percentage? Is that a matter of how the algorithms are built? Is that a matter of technology?
Yeah, thank you. A very nice question and very important. I think that the answer is in several points. First thing, the modern AI is based on machine learning. So it's, as I've already said, it's not the only technology, but it's probably the most important. And machine learning works creating a model, a computer program, literally, from data. So it's dependent on the amount of data. And yes, if you if you use the current mathematical models, even very powerful, their limitation is always the amount of data. As soon as you have more data, you will increase the metrics, increase the quality of machine learning. But another point is that when we try machine learning in neurosurgical research, we have a hypothesis that the models should work. There should be any real pattern or real relation of outcome with some features. But in nature, the nature can be much more complicated. So the second limitation is the model architecture. We may believe that the model is good in predicting something, but we do not really know that. And if we increase the amount of data, it doesn't necessarily lead us to the quality of 100% in terms of accuracy. So the model is second limitation. The third limitation, to my point of view, is the cornerstone technology of artificial intelligence itself. For instance, I do believe that as soon as there will be some technological breakthrough, and we'll get some new concepts. It may be not machine learning, it may be anything else. We will also improve our quality in terms of our in artificial intelligence. But we do not know what this technology would be. So we would expect that in future. So nowadays, as you already said, if you have a good quality model, for instance, if you see that you have a model of 80% of accuracy, you should be you should know if it's enough for your clinical task, if you will do well with 80% of accuracy. If not, you can always think about another solution, maybe not machine learning, maybe not artificial intelligence.
写真は
写真も良かったです。
あ、
綺麗に撮れ
よかったね。
はい。
どこか違う
So I do believe that at the current stage of AI development, the increasing amount of data and choosing the right model is the only solution to improve AI. But as soon as we get new technology in the under the hood, it may be something else. We do not know. I'm not sure whether I made myself clear, but
Yeah, very clear. I think
those
it's also a very nice message about the importance of putting efforts together between different centers. In my idea, probably a good way to improve this accuracy is to, join forces between different labs, different clinics, increase data in a significant way. That can be one way to improve. Thank you very much for your reply. Is there any other questions from the floor? Issue?
Yes.
Yeah.
Can I?
Thank you for the wonderful lecture, Dr. Danilo. I'm a beginner. I don't know much about artificial intelligence in neurosurgery. So my question is very simple. Like, how to begin? How to start? Like, how did you learn so much thing about AI? And because the data was very, very new and beyond the my IQ level. So I'm asking the simple question, how to start?
Thank you. To be honest with you, I think that might be a long way, but the first thing I would do as a doctor with any knowledge in artificial intelligence is to find some technical AI person to cooperate with. That is a really hard task, because first of all, you want to understand each other. You will talk different languages. That's a huge problem. But if you try to engage people, to involve them technical, I mean, people, to involve them in your research process, it may take months and it may take years, but you will certainly improve only if you do not give up and continue working together. If you are talking about getting some knowledge about artificial intelligence, that is a bit more complicated, because it depends on the level you want to know AI. If you want just to get an impression of what's going on in the area or what people do with AI in medicine, you can read some systematic reviews on the topic. There are plenty of them, and you will get impression what machine learning can do, what AI can do. Another way to get more closer to AI is to take some courses like Coursera courses or any online. There are plenty of them, but be aware of some limited knowledge that you will certainly get from that courses. The best way is to have these courses, have this communication with the IT specialists, and try to plan your own research. So to start, try research in the field.
Thank you. Thank you.
Danilo, thank you very much for the nice talk. Just I want to ask two things. One is, when does it commercialize? When we can use with the technology, and also can you predict the quality of the pathology? How deep? And also maybe the complication avoidance. can you expect with your technology and also the prognosis? Thank you.
Thank you. It's really hard to predict something in this area just because medicine is not that is not that active in applying artificial intelligence. However, there are lots of medical devices that use AI nowadays. There is no any breakthrough of thanks to artificial intelligence in medicine. So I think that we can expect something maybe in few years, but never knows. At least in our country, a lot of efforts nowadays are put to bring artificial intelligence into medical practice. As for complications prediction, what I would say about our study and our experience and what we work on now, we're mostly working on detecting complications from medical records. So what we do is training a robot, machine learning technology, to recognize different phrases related to specific complications. For instance, we can that is the way we collect data about pulmonary embolism, about paresis, about meningitis from unstructured medical text, and that allows us to build some profiles of safety in neurosurgery. So we do not predict the complication, but we detect the complication, and that is probably nor less important than a prediction. As soon as you visualize your complications, you can somehow rule them. So I hope I answered the question.
Okay, thanks a lot.
Thank you so much.
We have Temur Dushanov who raised his hand. Temur.
Thank you for a great lecture, Dr. Danilov. I have one question. So it is interesting to many young doctors that which specialties, especially in medicine and also in neurosurgery, will be obsolete because of the advancement of the artificial intelligence. For example, what do you think about functional neurosurgery? Because we know that we have Neuralink, which is very precise and can like insert electrodes to the brain. Or, for example, endovascular neurosurgery, which is only advancing and retracting and turning the catheter and so on. Maybe this can be also learned by machine learning. So what do you think about that? Thank you.
Thank you. I think that functional neurosurgery is one of the most prospective fields for applying AI, just because it handles a lot of data. EEG, electrocardiography, and all the types of time series that can be collected from human brain is a direct subject for applying artificial intelligence. And I know that there are studies in the field of functional neurosurgery. We are also interested. For instance, you can apply some machine learning and AI to improve the accuracy of target prediction for stimulation in functional neurosurgery. But I agree that functional neurosurgery is a very promising area in that aspect. Yeah.
Thank you. Felici? Yasin?
Yes, thank you. Thank you, Dr. Danilov, for your presentation. Nice presentation. I have two questions. It's about what do you see as the next big step for the AI neurosurgery research? Is the first question. And the second is, are there any specific application in neurovascular surgery that you believe that AI is particularly suited to enhance in the near future?
Thank you. As far as I understand, you're asking about the future of neurosurgery. So what would be the next step in my prognosis? Well, we've already discussed it in part. I do believe that the closest future is using transformers architecture in text classification, generation, summarization, in image processing like object recognition, object detection, object tracking, because in neurosurgery, the main sources of, I would say, not big data, but sophisticated data are medical images and medical text, as well as time series from devices, from implantable and wearable devices. So I think that there can be some improvement in model architectures as soon as the computer power will increase, and it always happens each year. We will probably get better better performance of the types of technology, and probably, as I've already said, we will try to improve the performance with more data, like in multi-center projects or in using some special data banks based on single centers. Who knows? But I would expect some really breakthrough with new basic technological advancement in AI or in computer technology. So with these types of models, we can do something, we can do well, but we do not know whether we can make any solution for an expert level, like decision making. Real decision making is much more difficult and much more sophisticated than any mathematical model. So I do believe that the advancement in basic computer technologies are needed to discuss decision making. And you talk about neurovascular technologies.
Yes, application in neurovascular.
Well, I know that there are some studies on predicting treatment outcomes. And we also, at our center, we also conducted a study on predicting treatment outcome of aneurysm surgery. And there are some studies in modeling hemodynamics, in segmentation of neurovascular structures, and you can probably find specific systematic reviews to get more deep in detail in that topic. But I haven't heard yet about some medical device specifically for neurovascular neurosurgery. Maybe augmented reality or neuronavigation, but that's not any news for you probably.
Thank you. Thank you, Professor Danilov. Is there any other question? So if there are no other questions, I want to thank again Professor Gleb Danilov for a very exciting presentation and very active discussion. And we can move to the second speaker. So I kindly ask my dear friend, Professor Ishu Bishnoi, to introduce our next speaker.
Thank you. Thank you, dear Alberto. So I would like to invite our next speaker, Dr. Temur Dushnov. He is a neurosurgeon from Uzbekistan, Tashkent. He did his neurosurgery from the Tashkent Medical Academy, and then did fellowship under Professor Yoko Kato and also under Professor Bakshaya. And he is trained in vascular neurosurgery, spine surgery, minimal invasive endoscopic spine surgery, and skull-based surgery. Currently, he is working as assistant professor and deputy dean at the School of Medicine, Central Asian University. And he is a very good spine surgeon, and specifically endoscopic spine surgery. So today his topic will be on endoscopic spine surgery. I would like to invite Dr. Dushnov to present his presentation. Please.
Thank you. I want to use my chance to thank you for the invitation, Professor Yoko Kato, Professor Alberto Feletti, Ishu Bishnoi, Raja, Bunsenglu. Thank you very much. Nice to see you again. I want to present today my topic. It is focused on full endoscopic spine surgery. So why full endoscopic spine surgery? As you know, I always trained in cerebrovascular and 𝒂𝒏 surgery, and I can probably say that the full endoscopic spine surgery is the closest thing to brain surgery because it is very microscopic, so meaning that we will operate within millimeters, like 5 millimeters, 3 millimeters, and so on. So this specific topic is directed for beginners, how to start, what to avoid, and how to minimize the complications. So it will be your guide for starting the full endoscopic spine surgery. So the evolution of spine surgery, especially minimal invasive, we know that first it was started with open surgeries, 70s, 80s, that is microscopic spine surgery. Then the tubular microdiscectomy was introduced, and in 80s, the first one, which is used the Kanban triangle, which is transforaminal lumbar discectomy, which is performed by Kanban in 80s. So, and then the next evolution of the minimal invasive spine surgery is the full endoscopic spine surgery. One is monoportal, the other one is UBE, which is a unilateral biportal endoscopic spine surgery. But I'm personally use monoportal full endoscopic spine surgery. So we know why this is important. So despite the tendency to stay in place, especially in European and also in USA, spine surgeons, so they do not trust that first for endoscopic spine surgery, and they continue to use the fixations, open surgeries, and so on for the treatment of the, for example, disc herniation, and also the fixation systems for the treatment of the stenosis. But everybody now know that the full endoscopic spine surgery has more advantages over the any open procedure in the treatment of the stenosis and also in the treatment of the disc herniations in any kind of patients, especially in obese patients, in diabetes patients, and so on and so on. So that's why we need to know, as this can be our one way to moving into the private practice, especially for young neurosurgeons. For example, in Uzbekistan specifically, it is almost impossible to do skull-based surgery in private practice. And government hospitals, for example, they have already like overstaffed, so there are no like place for any young individuals and so on. But this is an opportunity for young neurosurgeons who are already practicing either spinal or either skull-based or cerebrovascular to have this technique, so you can start practicing in private sector. So why endoscopic spine surgery? Uniportal full endoscopic surgery or uniportal stenotoscopic spine surgery has a lot of advantages. It is less tissue damage, reduced pain post-operation, quicker recovery times, less intraoperative injury due to high definition visualization. Our weight is not a problem. And also, why these advantages we will talk about in a moment. So, and also my first two patients were obese, also more than 120, 135 kilograms without any complications, discharged the next day. So what are the cons? There is no 100% good way of treating. Of course, there is a cons. The one con is the learning curve for full endoscopic spine surgery. So you need a little bit of cases, like 35 to 50 cases you need to in order to master the disc herniation or disc herniation surgeries before to moving to complex spine cases. So there is a saying, I have not failed. I've just found 10,000 ways that won't work by Thomas Edison. Or success is going from failure to failure without a loss of enthusiasm. So in neurosurgery, there is no way for quotes like this because we don't have the right to fail. We don't have the right to make a mistake if we can avoid this. So that's why my topic is focused on minimizing minimizing the complications. I had only one, for example, one dural tear throughout my endoscopic spine surgery career, more than 300 cases now, but only one dural tear, and without the patient also discharged without any deficit or neurological signs. So failure is not an option. We should be like pilots. We should be like Formula One drivers and so on. So we have not the right to fail. So in the first 50 cases, if you do not fail, there will be 0 complications almost. So how to start? In order to successfully start your practice, you need no major complications, first 50 to 100 cases. Do not broke the scope first for 50 to 100 cases. Why? Because firstly, if you start private practice first, we have ourselves bought the endoscopes. So that's why it costs a lot. So you don't need to break them, and need a minimum necessary equipment, of course. The know which patients to operate on. The patient selection is very important, and also, if possible, have senior neurosurgeon, a full endoscopic spine surgeon, to help to manage complications. So in my case, for example, in more than 300 cases, I have 0. I hadn't once transferred from endoscopic surgery to open surgery, not even once. So first cases, you should be very super selective. Do not rush to patients. Choose them precisely. Which kind of patients we will talk about now. So this is the basic minimum equipment, not much. It is a scope. It is the scope. It is the instruments we can see here. So we can see here. Sorry. So this is a scope. Our scope is 120 millimeters in length. The working channel is 5.7 millimeters. It is very versatile endoscope. Why we choose this? We can operate interlaminally with this scope, and also we can operate the extraforaminal herniations also with the scope through paraspinal approach. So this is the scope which you need. You don't need any other scope. So this is the basic, of course, Kerrison rongeurs, the 3, 2, and 4 millimeter Kerrison rongeurs, the punch, the pituitary punch forceps, and the working sleeve, and also obturator, and also root retractor. Then the hooks, of course, and dissectors. And also, you will need the ablator, which you can use to ablate the anything bleeding, and also the saline. You need a lot of saline. For our case, it is like 10 to 12 liters per level saline, sterile saline, which is used to irrigate the endoscope. So, of course, many hospitals have the tower, the endoscopic tower. Many have. You don't need to buy them. So you need to have the drilling system, Stryker, for example, and so on. Any kind of drilling system, and also the C-arm, and then the drapes, very important. So you'll have specific drapes. So all of the flow of the water will flow down to some kind of collector, and also very high table, which is used for the nurses. So this is a basic setup for the operating room. So as we've said, the super selection of the patient is very important. First, I really recommend L5 and S1 paracentral herniated discs, not central, not extraforaminal, not any levels. Why? Because if you don't have any experience with spine surgery, it will be very difficult for you, because I had zero experience in spine surgery and moved right away to the endoscopic just by picking the right patients first. Then you will get the confidence, the feeling of the anatomy, and so on. Then you can move to the other levels and complex cases. So large interlaminar window and age is less than 50, not older than and also not younger than 25-year-old. Also, why not older, younger than 25-year-old? Because young patients have really more central disc herniations, very bulging, like for example, bulging from both sides disc herniations, central located disc herniation, that will be very difficult to remove. But the middle is very like gold, because you can just remove the sequestrated disc herniation, and this will be enough. So do not pick the revision cases ever before your 100 cases. Not to complicate cases, and no to multiple levels first. So after 25, 30, 35, 50 cases, you can move to the complicated cases or to the multiple level cases, like 2-level cases and so on. And also you should avoid as possible huge wide base herniations, as we've said, because more retraction is needed. You can be afraid first when you see that there is a urinary retention or something. So if 2 herniations, always you should operate the one which is causing the symptoms. Do not operate both. Tell the patient that the other one you will do a follow-up, because 99% of cases, only one disc herniation is causing the problem, not the other one. Avoid calcified herniations and osteophytes in the beginning. Then you can move, of course, to this kind of cases also. So the preparation is the most recent MRI. It is preferable within a month. The CT 3D interlaminar window to review the interlaminar window, the calcifications, lumbarization, sacralization, and so on. I always did the CT for all of the 50 cases, but now I don't do the CT for middle level, which is middle difficulty level cases. I do not do any kind of CT. So, and have all of the images on the large screen or computer next to you in the OR. And also first 10 to 30 cases do not do with general anesthesia. Why? Because the psychology is everything. When you have the patient with spinal anesthesia and you are just starting the case, first, for example, patient or second patient, it creates a lot of pressure to finish the case within 2 to 3 hours and so on. So that's why general anesthesia, there will be no spasms of the muscles and so on. You can operate 2, 3, 4 hours and so on. My first cases was like 3 hours, so it was not a problem. And also treat the patients, not the MRI. Always only symptoms which are correlated with the MRI. And also, you should instruct the patient to stop any drugs which affect the blood coagulation, aspirins, warfarins, and so on, in order to reduce the bleeding. So before the surgery, shot of antibiotic. Usually we do ceftriaxone after negative test, and also have senior endoscopic spine surgeon beside you to help if there are any kind of complications or difficulties. What kind of complications? For example, first, if you are not familiar with endoscopic spine surgery, it will be difficult to find the interlaminar window. It will be difficult to find the ligamentum flavum. For example, first cases like first case or second case, so on. You should have the senior surgeon. Then checklist, of course, ask the patient the side and name of the patients in the operating room before the anesthesia. So I always do this, 0 errors inside within my surgery, 0 errors. Always use a checklist directly before the surgery, asking the patient. Controls the operating nurse, for any errors or mistakes with sterilization. Why? Because they are new to the surgery also. You need to control the nurses for the sterilization of the drapes and so on. How to do anything, you should teach them. Warm to body temperature is a saline, and also you should add adrenaline and 0.5 1 milligram per liter, which will help reduce the bleeding. Actually, first like 30 cases I have operated without adrenaline. I did not know this, so there was a lot of bleeding in the soft tissue first. But after I knew this, so it completely changed the surgery, how I do the surgery, the amount of time I spend for each level, and so on. Very important. And it will not like increase a lot the heartbeat. Do not worry about that. So during the surgery, priority is very important. Quality over fast first. So always quality is first. My first cases was 3.5 hours. This is a lot. For example, you can do microdiscectomy for 30 minutes, but for full endoscopy, it's 3.5. But nowadays it is approximately from 30 minutes to 1 hour and so on. So first 10 to 30 cases do with AP and lateral view, always. Why? You should know the size of the interlaminar windows, the level of the interlaminar window. Nowadays, I do not do, for example, AP view, just the lateral and start the case. So puncture with scalpel is enough to cut the skin and fascia. Be careful with very thin patients. For example, if this is very thin patients, you can even go to the ligament of flavum. That's why you should be very careful. So there is no incision, only puncture with a scalpel. During the surgery for multiple level, you can use jumping technique for 2-level cases. Of course, first you will not do the 2-level cases, but if you have, you can do the 2-level cases by jumping technique, which is you will cut the skin, and then through the same techniques, through the same skin puncture, you can jump to the other layer of the fascia. You will just cut the fascia. So there will be one incision in the skin, 7 millimeter incision, but you can operate in 2-3 levels. First, I will not recommend to do this jumping technique until you have experience with 50 cases. So handling of the bleeding, how we handle the bleeding. The most important part is the managing the complications. Because if you know how to manage complications, as I know, any neurosurgeon can handle any surgery. You should know prior to surgery how to handle complications. It is the use epinephrine in saline solution. Soft tissue you can manage while it is small with bipolar cautery. And also bone bleeding, you can use bone wax, or the most commonly used is you can compress with the tip of the kerrison punch, kerrison ranger. So you can just compress the bone and it will stop. Uncontrollable bleeding. So I had one patient with uncontrollable bleeding from the posterior side of the dura. It was coming from some artery within the bone. So it did not stop at all. So one thing is that you can put the obturator into the working channel and wait. Just wait for the 15 minutes. Eventually, the bleeding will stop and coagulate. Then you can suture, or you can again come in and then continue the surgery. So I had only one case with such bleeding. It is very, very rare. For stenosis decompressions, put drainage and remove the next day. Because we had patients after the surgery which had pains in both of the thighs, for example, both legs, and so on after surgery. The reason was the accumulated epidural blood compression, which was compressing the dura and the nerve roots. So the next day we went to surgery and removed the blood clots and put the drainage. Nowadays we put to all of the stenosis cases, we put the drainage no matter there is a bleeding or not. But for the dysherniation PH patients, we only put when there is a profuse bleeding. So what to do with a dural tear? First thing, you should avoid it because I did have only one patient in this 300 cases with the dural tear, and there actually the nerve roots did not go outside. Why? Because the arachnoid and the layer under the dura, the first layer was intact, so the roots did not go outside. So it was very minor complication. If you bite what you see, there will be no dural tear at all. If you do not rush, there will be no dural tear at all, because I did not have any asthma. So if there is a big tear with nerve root floating, have someone with experience to suture endoscopically. Fortunately, we had in my beginning endoscopic spine surgeon who can suture with this monoportal endoscopic technique the dural tear using the pituitary forceps. So with my colleagues, we had a tear, he had a tear, dural tear, and he helped to suture it endoscopically. There was no problem after the surgery. So there was no conversion to the open surgery, not even once in our clinic. Actually, in our clinic, there were done more than 3,000 endoscopic spine surgeries totally. And also, patients stay in bed for 3 days after suturing it. So no need to any kind of drainage and so on. So do not bite or cut what you don't see. So post-surgery antibiotics, of course, NSAIDs, brace for 1 month. This is our protocol. Of course, for braces and so on, I do not know. I do not think that there is evidence that can like help to tell you that it is beneficial, but it is beneficial for patients. They will not bend. It will limit their movements and so on. So it is beneficial to limit the patient's movements. That's it. And also limit the weight lifting up to 5 kilograms next 3 months. Restrict driving for 1 month. And MRI and scan CT after 48 hours. And also if mild paresthesia due to traction, for example, for central herniation and so on, usually we use prescribe the dexamethasone, 8 milligrams, 3 times a day for 3 days, then taper down. And also in stenosis cases also, we use dexamethasone for 2 to 3 days. So this is, for example, a case, lumbar 4-5 lateral recess stenosis. So left side, this disc herniation, 63-year-old male with left leg pain. We can see there is a disc herniation which is compressing in the left lateral recess. So the surgery was done. So we can see the laminectomy. So removal of the disc herniation. This is the nerve root. So after removal, so this is basic technique to show you just. So this is removing from the axilla. So this is a post-op images, MRI. We can see relatively very good decompression of the nerve. Patient who left the hospital discharged the next day without any pains. For example, next case, 36-year-old female obese patient presented with right side L4-5 radicular pain, suffered for months, unable to walk due to pain. Post-surgery, any genital area paresthesia, difficulty urinary retention. Why? Because the patient was obese, and this was one of the first cases. I retracted a lot the roots, so that's why there was an anogenital area paresthesia, even analgesia, and also the urinary retention. We do not went again to the surgery but we did give dexamethasone, 8 milligrams for 3 times a day for 3 days. and the patient improved completely for the third day and discharge. So this is actually the patient. So this is actually the patient. We can see. So this is a patient after 3 days without any kind of symptoms. You can see very obese patient. One of my first cases. So this is next case, 34-year-old male presented with left side L4-5 disc herniation with radicular pain, suffered for years. This is patient from Tajikistan, I think. You can see. Yeah, this is after a day leaving the hospital to another country, Tajikistan. So this is pre-op, this is post-op. You can see complete removal of disc herniation without any residual, and also with adequate decompression. So there are a lot of cases. We can see a patient from Bukhara. We can see disc herniation big after MRI, no pain at all. Discharge next day. We've operated his relatives also last month, discharged in very good shape also, without any pain. So this is also another case with relatively very big disc herniation and located a little bit centrally. We can see adequate decompression and improvement of the symptoms. And in other case, we can see, yeah, the other case also. So every patient has a very good outcome. That's why I think every neurosurgeon should try to master the endoscopic spine surgery. For stenosis cases, we will leave for another talk. It is from last my talk, so I will present for another day. Thank you. So here we can see another patient with 3-4 disc herniation, relatively located centrally, bulging. So we can see the decompression. I performed bilateral decompression in this patient. You can see the ipsilateral and contralateral nerve roots. So thank you everybody for the attention.
Thank you. Thank you, dear Dr. Semu. So now the house is open for the discussion. So Dr. Ashish, please.
I see actually two hands. So
Okay.
I think, yes. I think Dr. Biswas, I think your hand was right up. So go ahead and ask questions.
Sorry, Ashish sir. Actually,
keep going. Don't worry. Go ahead. Ask your question.
a lot of questions I have, if you permit.
I could see that.
For the endoscopic spine surgery, this system is actually the PSLD system, I guess.
Yes.
Percutaneous stenoscopic lumbar discectomy. So just my one question, where do you dock the endoscope and the spinal laminar junction the way we do in microscopic surgery?
What do you mean?
I mean, where do you dock the obturator or the endoscope in the interlaminar, like you're working on L5S1 and on the left side.
Okay.
So you dock the obturator over the spinal laminar junction, then you rotate.
It doesn't matter actually. When you so actually what matters is where you do the skin puncture. So it should be very close to the spinous process.
Okay.
Then when you go inside, actually with obturator you can feel the lamina and the interlaminar window. That's you can even dock to the ligament of flavum. Doesn't matter. You can dock directly to the lamina. Doesn't matter.
Like for the L5S1, I can directly land over the lamina. I mean ligamentum. But
Yes.
for the L45 it's quite difficult because the space is not directly just in between this minus process. What do you
Yeah.
suggest?
So when you are docking, for example, if there is a disk space, usually when you are docking here, so for example, this is disk space, the interlaminar window in the L3, 4, for example, or 2, 3 will be a little bit lower. So you will dock a little bit lower, actually, to the lamina, you can feel that. So then from here, you will go to the up side. So you will dock here, you will insert the endoscope, then you will palpate, and then you can go up. If you have any difficulty to finding the interlaminar space, you just go directly to the joint. You should find facet joint, and then there is, it is facet joint, there is a fat, you can even open it if you want to confirm. Then from facet joint, you can go up midline to the midline.
Okay.
So.
And two more questions. As a beginner, what do you suggest for the fenestration, like for drilling or Kaysen puncture?
So, for the fenestration of what?
I mean, like in interlaminar space, you were working like in 4-5. If we had to go for the fenestration, I mean, a bit drilling of the part of the lamina at the spinolaminar junction.
Yes.
Do you suggest as a beginner, should you use a drill or punch, or what is your advocacy in this regard?
So I advocate to use the punch at the beginning, yes, because in order to first, you as a beginner, always I recommend to do the CT, so you can know exactly the level of the disc space and the structure of the interlaminar window. So you can be 100% sure if it is narrow or if it is wide and so on. If you don't have anything, first you will try, of course, the punch, Kaysen punch. If the interlaminar window, of course, if the lamina is very thick, of course, you have no other option to not use the drill. But actually, we do not have the drill first 30 cases. Then I brought the drill with myself from US. I bought it and brought it back. So first we use the punch only to advance to the final side. It was enough.
Okay. Last questions. There is a couple of cases we had to go for the microscopic surgery due to bleeding, and we don't have RF. So do you have any alternative technique to RF to stop the bleeding? Like in ETV, we use pointed bipolar. Is it possible to use that bipolar in this system? Or you have any alternative technique to RF?
So you don't need actually radio frequency. We use bipolar. Actually, very basic. I don't even know the radio frequency. Is it 4 megahertz or so? But we use actually bipolar. I can, if you write me, I can send you pictures. It's very like common one which is used. Any kind of bipolar is enough. You can directly connect this electrode probe. You can use that as a bipolar because the actual probe is just 2 metals. There is a little bit space in between. That's it. So any kind of bipolar, actually for beginners can be like enough because very expensive RF.
Yeah, it's very expensive.
You don't need that. You need only to actually you will not have any kind of bleeding which is on top of the nerve. So it is not necessary at all to have to preserve this kind of thing. So you will use this in lateral recesses where there is no any kind of root and so on. You will not directly put it on the roots and so on. Of course, you can put directly on the root also if there is a little bit of bleeding with the lower levels of the bipolar.
Oh, thank you, sir. Excellent. Thank you. Thank you, Ashish, sir.
I interrupt the discussion, but we have Dr. Jeremy, who is gonna take a flight soon. Maybe if he is still online, he wants to give a 5 minutes self-introduction. Jeremy, are you online? And then we can keep discussing about Dr. Temur's talk. Jeremy?
Thank you, Professor Alberto.
Yes, I know.
Sampai?
Professor Cato also donated a drill, right?
Yes. So maybe I can make a short presentation.
Yeah, please. I know you are in a rush. You are gonna take a flight soon, so you have a few minutes for the self-introduction before you leave.
Okay, thank you very much. I think you can see my screen.
Yes.
Okay, so this has been my good experience at Fujita. I came to Fujita on 1st of September this year, and my last day was the day before yesterday. This was a brief of my long flight that I had from Kenya through Doha to Tokyo. There was a small typhoon we met just before getting into Tokyo, but we were able to go through it and land safely. I was able to be received by some of my fellows who are coming from Bangladesh. And this is just the welcoming dinner that Professor Kato organized, and the wonderful dinner and the sweet food that the Japanese offer was actually a good welcoming for me. I got to be exposed to a lot of new equipment, a lot of procedures in neurosurgery, including CFD, which is a diagnostic used for assessment of aneurysms and the preemption towards rupture. We met Professor Takizawa. He came in just when I had come, and we were able to clip a basilar tip aneurysm, which was a good experience for me since I'd never seen it in my country. We were able to go through some of the other procedures like VA shunts for elderly patients with normal pressure hydrocephalus, and even had these huge meningiomas that were intraosseous that we were managed to manage well, and the patient did well postoperatively. We also got to experience some spinal degenerative diseases, which were done by visiting professors. Some of the faculty, including Professor Haraguchi, took us through endovascular management of aneurysms, as well as carotid artery stenosis. And I was exposed to these new techniques that in my country, I was just able to read in books. But when I came here, I was able to experience the flow diverter, the intracircular devices, and also the coils. Professor Komatsu took us through endoscopic microvascular decompression. So many cases he took us through, and I was able to see his wide experience in microvascular decompression. We also go to scrub in into some of the emergencies, including this patient who presented with an M2 infarct, and we were able to do endovascular management for the obstruction, and the patient did well after the procedure. Professor Kato also organized for us to travel to other centers. So this was our experience at Fujita Main Hospital, and we were able to see this functional neurosurgery, including posterior calosotomy for patients who had intractable seizures. And we were also able to see input of SEEG probes for a patient who also had intractable seizures. Then we also went to Nagoya Hospital, and we were also able to see management of patients who had dystonia, and it was a nice experience and first exposure for me. Then we also went to Aichi Medical University, and Professor Sunsuke was able to take us through resection of vestibular schwannoma by use of the OB-eye, which was also my first experience to see the OB-eye, because we are used to using the microscope in my country. So this was also a very wonderful experience for me to see. We also got to organize to attend a lot of workshops from endoscopic hands-on course. We also went through a cadaveric course for transcavernous approach at Kyorin University with Professor Nakatomi. Then we also taken through endovascular simulation courses at Fujita, at Bantane Hospital. And these were some of the skills that we picked up as first experience in this fellowship. Professor Kato was instrumental in enabling me to publish this paper on normal pressure hydrocephalus and the technique of insertion of a ventricular atrial shunt. So this is a technique I was able to scrub in and see. And I think when I go back to my country, this is a skill I'll be able to do in my country and promote its management. Professor Takagi also, who is a proponent of management of this normal pressure hydrocephalus through the VA shunt, was a faculty in Bantane, and so one of these meetings that were organized by Professor Kato to attend, we were able to get a first-hand experience from his wide experience and able to learn and inculcate the technique in me. Professor Kato also organized for us to attend the 83rd Japanese conference, and with my co-fellows, you can see down the lower left picture there. This conference was a good exposure for us to meet a lot of Japanese neurosurgeons. We were able to make contacts with them, and through these contacts, I know I'll be able to come back again and do another fellowship here in Japan. Through this conference, we were able to also go through some techniques. We went through the Medtronic hands-on course, and you actually taught on how to do the eggshell technique. We also went through the grid system, which is a neuronavigation technique that is utilized in the simulation of tumors and approaches for surgeons. So this was a good exposure for me too. I was also able to handle this 𝑘INEVO 900 microscope, which is an excellent microscope that, and its clarity was actually amazing for me to see and see how effective it is in visualization of even the smallest tumors in brain. Apart from a lot of the academics, Professor Kato organized for us to visit some of the centers in Nagoya. So this was the Nagoya Aquarium. We went there to see this exotic whale, which is actually at risk of extinction, but through this aquarium, we were able to preserve this species, and this was a wonderful experience for us. So we also went to some of the shrines, and Professor Kato organized for us to see these wonderful shrines, and it was a good exposure for us to see the Japanese culture and learn a lot from them. We also went to the Nagoya Castle, which was also a good heritage site for Japan, and went through the history of the Nagoya Castle and how it was remade after it was broken down during the war. This was also another shrine that Professor Kato organized for us to see, and it was a good place for us to see. Apart from these shrines, we also attended some of the music festival, and this was organized by Professor Kato, and with my colleagues there, we loved the wonderful music that was played in this orchestra. Professor Kato has this annual patient support group meeting, and which is a very wonderful meeting for us as surgeons to interact with our patients so that we don't just stop seeing them after they get well, that we can still follow them up and interact with them out of the hospital, and this actually contributes to their good health. And so, Professor Kato, this is a wonderful progress that you do, and I want to encourage that you continue with the same. And this was a wonderful thing to learn that I can actually inculcate in my country. Wow. So Professor Kato organized for me to get this drill, which will be a wonderful contribution to neurosurgery in Kenya and in my country, in my county hospital, which I'm going to be the first neurosurgeon. So this drill, I'm actually having it on my way to Kenya at the moment, and I know this will actually help bring up the standard of neurosurgery in my hospital. So thank you, Professor Kato, for this wonderful donation. So we also met some other Bantane fellow at the conference, and I'm happy to say that this was a wonderful meeting, and they all praised the experience in Fujita. And I want to say that the experience at Fujita is outstanding, and I will encourage any other fellow out there who wants to have an experience in Japan, then you'll be welcomed to visit Bantane, and you'll have a good exposure and experience at Bantane under Professor Yoko Kato. And this was just a final photo of me and her the day before yesterday as I was signing off my experience at Fujita. So thank you very much for this wonderful experience at Fujita. Thank you, Professor Kato.
Thank you, Jeremy, for this very nice report on your experience at Bantane Hospital. We wish you all the best in your country and safe flight back. And also, please join the Fujita Bantane Alumni Association and be active with us during our initiatives.
Thank you so much, Professor Alberto. I will be happy to join. Thank you.
Great. Thank you very much, Jeremy. And okay, we can go on with the discussion about Dr. Temur's talk. I think there was at least another issue, right? Dr. Ajit.
Dr. Ajit, yeah.
Ajit.
Yeah, I also had a question.
Yeah, Dr. Ajit is here. Yes, Dr. Ajit.
Yeah.
Maybe
Can you hear
Thomas,
me?
you first.
Yes, we can
Thomas,
hear you.
Yeah. It's a very good basic presentation about the endoscopic discectomy. I just want to make a comment and his opinion regarding. He has shown taking out a disc from L4, L5 level, and it is labeled as intra-axillary. And actually, as what is in endoscopic discectomy, what we say that L4-5, there is a lot of laminar overhang above the disc space, and the root exit almost below the disc level. And L5S1, it is usually above the disc level or at the disc level, most of the time disc root exit. And there is no need for any removal of the bone or laminar facet junction there. So how come it is possible to take disc out of L4-5 through intra-axillary route? And how much of the laminar facet junction you drill before taking disc from the L4, L5 if you do it?
Okay. So very good question. Thank you. Actually, when we remove the ligament of flavum, first thing is to go to the edge of the root. You should find the root, and then until the edge of the root, you can remove the facet joint if it is needed, but it is very small, like 1 millimeter, 2 millimeters. It will not do anything to the actual facet joint. We have performed CTs after surgery. Actually, what we see in the endoscopy when we remove it after surgery in the CT looks very, very small. So regarding the axillary removal, so first, of course, we will try to remove it not from axilla, but from the shoulder side. But depending on the anatomy, as you know, that the anatomy differs in each patient. Even nowadays, for example, the roots come out directly horizontally, or roots come even there might be no roots at all, which will exit from the other root, other level with 2 roots, and so on. So it depends on anatomy when we remove the disc herniation. Of course, the preferable way is through the lateral margin of the root shoulder. If it is not possible, we do from the axilla, and it doesn't, in endoscopic spine surgery, it doesn't create any kind of difference.
Okay. Yes, my question is for L4, L5. Usually there is a laminar overhang there, because when you L5S1, the whole disc space is within the interlaminar space most often. Whereas L4-5, the L4 lamina overhang the disc space. So we have to drill a bit of the laminar facet junction, and sometimes we have to remove the SAP, what we call the superior ascending process. of the inferior facet. But your technique, L45, is it possible without removing these things? And what do you mean without causing much of root retraction? You have to access the disc space without removing the bone.
So yes, it is possible if the interlaminar window is large. But if the interlaminar window is not large, there is no necessary to retract a lot the nerve root. The main thing is that you can drill the bone lamina till the ligamentum flavum attachment side to the lamina. Till the end, you can drill that. There is no difference. It will not create any kind of instability or any kind of fracture and so on. So for example, lamina, there is end of the lamina. You can drill that, cut off the lamina, and then you will go to the side to find the actually the lateral margin of the dura and also the shoulder. Then when you find the shoulder, that's enough. Then you will go to the actually removal of the disc herniation. The same thing in stenosis, for example. When we see in the MRI, there is a margins of the dura. So till that margins of the dura, you can remove the facet, for example, SAP and so on. It doesn't. There was no any case, especially in our clinic, more than 3,000 cases, any case of instability. You can remove till the margin of the dura and the shoulder. It will not create any kind of stability.
Okay, great. Issue, I think we can move on with other questions.
Professor Feleti, I had one question.
I don't know who is talking now.
Dr. Farhad.
Yes?
Yeah.
Yes, yes, Dr. Taimur, nice presentation.
Thank you.
Yes, I had a question that what are you use the uniportal method, and what is the scope you purchase? Is this storage scope or purchase from other country?
Actually, the manufacturer of our scope now, it is manufactured in Germany, but the company actually Indian, MP.
Okay.
Yeah.
Okay.
Yes.
Just last question. Very important thing. I feel that counseling regarding the outcome. How do you counsel regarding? I have seen one of the cases you have shown that a patient had anogenital paresthesia and then also urinary incontinence. How do you counsel these sort of patients? Do you mention some specific points regarding these symptoms will improve or not? How do you counsel in these cases?
After surgery.
Before surgery. You get the patient. You see.
Before surgery, I do everything. So nowadays, I practice like ethical medicine. So I tell every kind of complication before surgery. I will tell. I will tell it in comparison with open surgery. So there are literatures. We have performed open surgery in other clinics. For example, we can compare the rates of the infection. We can compare the dural tears. We can compare the nerve root damage. We can compare the actually the instability, the rehabilitation after surgery, the time to return to normal activities. We will consult all of these things. And we tell the patient that there is no guarantee, but the complications are much more less than in open surgery, as in the literature already now and in our practice. For example, with this more than 300 cases, we had 0 nerve damage, 0. We hadn't any infections. Why? Because of the basic sterile saline irrigation. It will remove everything. So in any kind of, and also we really select the patients. If there is a for example, spondylodiscitis, we do not take it. Because if it is evident in the MRI and with clinical presentation, for example, back pain, standing back pain, walking back pain, and so on. So we do not take this kind of patients. Usually refer them to the tuberculosis clinic, because in the tuberculosis clinic in our country, they treat spondylodiscitis. So it is our country is like specifics. So I don't know any other country, but usually infection, spondylodiscitis is treated in different clinics in our country, not private practice.
Okay, thank you, thank you. Nice demonstrative cases and very soothing outcome. Thank you.
Two more questions. Yeah, Dr. Danilo.
Thank you so much. Thank you for your such an informative presentation. I know that there are some examples of you using computer vision in general endoscopic surgery. Do you, for instance, to recognize anatomical landmarks, do you believe that there might be some task in spinal endoscopic surgery for using computer vision and maybe any other type of artificial intelligence? What do you think about that?
Oh, yes. So actually, we are in the Central Asian University. We are starting research in implementation of AI and AR, augmented reality and artificial intelligence in the full endoscopic spine surgery. So I think this has really a promising future. So especially, of course, in using of the 3D models of the patient-specific 3D models throughout the surgery, for example, with navigation or QR navigation, for example, which is very not expensive. And with of course, supplementation with the augmented reality hand pieces like the, for example, Microsoft Lens or the Apple Vision Pro and so on. So this is an ongoing thing in our university. I cannot talk about specifics because there is a regulations, but we are doing some research on implementing of this. I think, especially in machine learning also. For example, one small thing, especially in endoscopic spine surgery, because it is irrigation, there might be bleeding. If it is from a real small artery, everything will become like red, completely red. So sometimes you will not notice where it starts, for example. But the machine learning system, which which analyze the video, can see it within the 30 frames per second, for example, and mark that region, and then it will stay there. So you can find that and blindly calculate that and so on. So this is one direction we are doing research. I think it will give some benefits in improving even the time of the stopping of the bleeding also.
Yeah, perfect. Thank you.
Thank
you. Any more questions? Yeah, Dr. Tawasul.
Good evening, everyone. Thank you for this nice presentation. I have one question to Dr. Taimur. Actually, the presentation answered all the question in my mind, but we used to use microdiscectomy in our country, okay? But I want to know, how do patient outcomes in terms of pain relief and time to recovery in minimal invasive endoscopic spine surgery compared to those for other minimal invasive techniques like tubular retraction and microdiscectomy? Thank you.
Thank you. A very good question. Thank you. So in our experience, for example, I actually, after the residency, I only practiced cerebrovascular and skull base. So I did only like a couple of like no more than 10 microdiscectomies. first, then directly moved to the endoscopic. But from the other, my experience in residency and also my experience with other colleagues, I can tell that the time to return to normal life actually really good. For example, after surgery, just we need to anesthesia to wear off from the legs, spinal anesthesia, and that's it. They can walk, they can sit and go home. But due to our regulation in our home country, we keep them for 1 day. So there will be very slight pain in the site of the puncture, zero pain in the legs. So it is very promising, a very good way of moving to private practice to anyone with very small complication rates, especially, for example, neurosurgery, if you do brain surgery and so on, complications rates are a little bit higher, and it is difficult to operate in private practice. But there might be slight paresthesias after surgery. It is normal. We'll recover for a couple of days, like 2-3 days. You can keep a little bit of dexamethasone for 2 days. That's enough. If there is a pain which is residual after surgery, this means one of two things. Either there is some kind of disc herniation, which is recurrence after they stand up, or this is hematoma if it is after surgery. So that's why patient selection, the site of the dermatome, which is neurologically evident, and plus in the MRI. So if you are not sure that this is the reason, you should not operate. For example, we have a clinic with 3 Tesla MRI in city. Any kind of like cases, difficult cases, I'll send for 1 millimeter slices, and this gives everything. So where the root exits, where it ends, everything, where it is compressed, where it is not compressed. So there was not even one single patient with residual pain. If you do correct patient selection, there will be no pain at all.
Thank you very much. I think I will go over and over this presentation. Thank you.
Are there any more questions? Thank you for the wonderful lecture, Dr. Temur. So there are no questions. You can proceed to the final conclusion.
Yes, issue. I think we can conclude, but we have one more speaker, new fellow, Dr. Absal, who maybe wants to introduce himself in a short time and tell us about his experience, previous experience, and also current experience at Bantane Hospital before we finish this webinar.
Yeah. Okay. Thank you very much. So I'll share my screen. So is it visible?
Yes, it is.
So my name is Abzal 𝒍𝒍 I'm 28 years old, a young neurosurgeon from Kazakhstan, Almaty. I work in National Hospital. It's Kazakhstan, flag of Kazakhstan. It's right in the middle of the Eurasia. This is green. We are bordering with Russia in the north and China in the east. So capital city is Astana, and the largest city is Almaty. Population is about 20 million. And I am from the Almaty. This is some beautiful places and landscapes of Almaty. And about myself, I got my bachelor's degree in medical university in Semey. It's in eastern part of the Kazakhstan. from 2013 to 2018, and I had my internship in general surgery for 2 years in the same university, and at that time I had exchange program in Ankara, Başkent University in Turkey for 4 months. After that, I went to residency to Burdanka Neurosurgical Institute to Moscow, where Professor 𝒂𝒏𝒊𝒍𝒐𝒃 works. And here I was in the department of basal tumors. My teacher was Professor Kalinin Pavel Lvovich. And also some prominent doctors also operated in our hospital. It's Professor Konovalov Alexander Nikolaevich and Professor Shkaruba Alexei Nikolaevich. And after the neurosurgery residency, I went to my home city. It's a small town, approximately 40,000 people living, and I worked here for 6 months. And after that, I moved to the Almaty city in Kazakhstan, and since May of 2023, I'm working here. It's our department. He's the first one is 𝒂𝒏𝒊𝒍𝒐𝒗 𝒂𝒐𝒂𝒏𝒂𝒏. He's a director of our neurosurgical department. He does maybe several hundred surgeries, and he's endovascular surgeon, several hundred surgeries in our hospital, and several hundred surgeries all over the Kazakhstan. And he, it's Marat Sarshayev. He's an open surgeon, and he's the head of our department. In our department, we perform 1,000 surgeries, about 1,000 surgeries annually, and half of them are endovascular surgeries, and about 70 to 100 MVD, about 50 to 70 brain tumors, and about 15 to 30 bypass surgeries. And also in our department, we have fellows from us in Bantana Hospital, from our neighboring states, Uzbekistan, Kyrgyzstan, Russia, Armenia, and India. And recently we had fellow from Uganda. And if some young fellows who want to learn endovascular surgery, they can come. We can provide apartment. So my main specialization is endoscopic transnasal surgery of pituitary adenomas, and I'm starting the resection of convex tumors and tumors of anterior cranial fossa, and starting endovascular procedures for aneurysms and stenosis. In Bantane Hospital, I want to learn and gain a deep understanding of neurosurgical anatomy through, if it's possible, cadaveric sections, and observe and learn new transnasal and endoscopic skull-based surgery methods, and learn endovascular surgical techniques. And in future, I am focusing in learn management of arteriovenous malformations. And in the end, I would like to express my sincere gratitude for the opportunity to participate in the observership, and the generous sharing your valuable knowledge and expertise. And especially I want to say thanks for Professor 𝒂𝒂𝒂𝒏𝒂𝒏 for accepting me to the fellowship program. And I am here only 3 days, and my impression on Japan is really great, and it's mainly thanks to Professor 𝒂𝒂𝒂𝒏𝒂𝒏. In 3 days, I learned a lot, and thank you for your attention. Any questions?
Thank you, Afzal. Thank you very much for this presentation. And I also want to say that you are also welcome to join the Fujit Bantane Alumni Association, of course. And I think I can express the wish of all of us, wishing you all the best for your experience in Japan. We are all sure that it will be a great time for you,
Yes.
from a scientific point of view and also from a personal point of view, I might say.
Thank you very much.
Thank you very much. Thank you very much. And good luck for everything. So issue, I think we can at this point finish this webinar today. We want to thank our speakers today, Professor Gleb Danilov and Dr. Temur Dushanov for wonderful presentations. And I express my gratitude also to all of you who attended, because the discussion was very, very active and very interesting. Thank you, Raja and Liu, for the support. Thank you to the discussants. Thank you to Ashish, our commentator. And the final words to Professor Yoko Kato to conclude this webinar. Please, Professor.
Thanks so much. It was 2 hours, wonderful, the webinar. So our team is more and more expanding and also stronger. And I think you may have more collaboration, of course. And if you have some help or needs, just ask us, please. No hesitation. Thank you very much.
Thank you, Professor, and see you next month.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Yasumi.
Thank you all.
Yasumi.
Yasumi-nasai.